Welcome everyone to our behavior change series, Made Easy. I'm Beverly Thomassian. My pronouns are she, her, and hers. I'm so glad you're joining us today for this little bit of a whirlwind presentation on different behavior change and learning theories and how to keep diabetes education person-centered and focused on the individual. Here's our amazing team, Brianna and Brent. They are here to provide awesome customer service and to help you navigate your journey and your professional pathway towards certification or toward just expanding your knowledge. And I know many of you here today are working towards your certification exam, so I'm so thrilled you're here. This information we will be sharing today will be very helpful for certification exams, whether it's CDCES or BC-ADM. And we also post this webinar for free, so your colleagues can view this information and we can get it out into our healthcare community. I'm Coach Beverly. I have no conflict of interest to share with you. Where did I get this information? Really, I culled it from different places, the ADA standards and standard 1 and 5, and there's also psychosocial resources available that I reviewed, and it's available on your resource page. And then the ADCS desk reference, you can see they have a lot of information here on behavior change, especially chapter 3, theoretical and behavioral approaches to the self-management of health. Okay, that's a long title, but it's what we're going to be talking about today. Before we get started with the content, I'd like to do a land acknowledgement. We acknowledge and are mindful that Diabetes Education Services stands on lands that were originally occupied by the first people of this area, the Mechoopda. And we recognize their distinctive spiritual relationship with this land, the flora, the fauna, and the waters that run through this beautiful area. What are we going to talk about today? Well, we're going to look at a person-centered and strength-based approach. We're going to discuss common behavior change theories that are used in supporting diabetes self-management. And we'll list the components of a person-centered interview and motivational interviewing. So we've got a lot to cover. I'm expecting that this will last for about an hour and 15 minutes, so 75 minutes, that's my goal. Well, the definition of a diabetes care and education specialist, or really any healthcare professional who specializes in providing diabetes care and education. A compassionate teacher and expert as an integral member of the care team provides collaborative, comprehensive, and person-centered care and education for people with diabetes. One of my favorite definitions ever of what our profession entails. Compassion, collaboration, comprehensive, person-centered. And this is from our 2022 National Standards for Diabetes Self-Management Education and Support. And if you're taking the certification exam, either one, this would be a great document to review in preparation. We definitely are considering and looking through the lens of social determinants of health and equity. When a person walks into our office or we're seeing people in emergency rooms or home health or in school settings, we're not just looking at that individual at that moment, we consider the social determinants of health. And which of these SDOHs are supporting them to getting best health or maybe acting as a barrier? So we look at education, access, and quality, economic stability and resources, social and community context, their neighborhood and built environment, healthcare access, and quality. So we recognize that we want to provide person-centered services that embrace each individual and acknowledge these social determinants of health. We want to increase and improve access and equity, focusing more on person-centered care and decreasing administrative complexities. Yeah, bureaucracy. We want to decrease that and make sure we really connect with people and communities in a meaningful way. So how do diabetes specialists help? Well, the ADCES has these 7 self-care behaviors that we coach people and we share strategies to reach these self-care behaviors if that's something they want to work on. So eating, being active, monitoring, taking medication, problem solving, healthy coping, reducing risk. So this is one way they lay out these self-care behaviors, and this is a more recent way, which I think is really so beautifully created and crafted, that the person with diabetes and the care and educator individual is in the center with them. They're on the same level, they're collaborating, they're sharing, they're listening, they're connected. And look what is on the first ring, healthy coping. So we know people can have all the knowledge in the world about diabetes self-management, but if they're struggling with different psychosocial issues or mental health issues, or they're struggling with diabetes distress, it may be hard to take those actions. So we recognize that and we support them on this journey. And we're trying to help move individuals and help them see diabetes from a new perspective, from dis-ease. I was just talking to a person the other day. I go, just because you have diabetes doesn't mean you're sick. It doesn't mean that. It means you have diabetes. It's a condition you'll need to manage for your life, that you still can be healthy with diabetes. And I think that's the framework we really want to share with individuals. We want to move from a feeling of dis-ease to enhancing well-being, whatever is possible for that person. And everybody has different abilities and limitations and social determinants of health. So what looks for well-being in one person might be different for another. That's okay, but we're going to help them move to their best life in this current situation. Let's do a poll question. RT often skips breakfast in the morning so he can sleep as long as possible before going to work. Since they take morning insulin, this often results in hypoglycemia. After meeting with RT, a plan is made to have a granola bar in the car to eat on the way to work. What does this exemplify? A, problem solving, B, adult learning theory, C, trans theoretical model, or D, the DASH approach? Let me launch this poll. So they skip breakfast in the morning so they can sleep. They take morning insulin, and as a result, they often get hypoglycemia at work. A plan is made to have a granola bar in the car to eat on the way to work. What does this exemplify? We'll wait about 30 seconds per poll question. And if this is your first time with a webinar with me, I just want to say, trust your gut, trust your instinct. And if you don't choose the best answer, it's totally okay, because this is a learning opportunity. We're going to give ourselves a lot of grace and just choose the answer we think is the best answer. And if it's not, oh, that's just an area I need to brush up on. Yeah, so we're going to be kind and gentle to ourselves. Let me close this. Well, you all can be kind and gentle to yourself because 94% of you chose the best answer. So we'll talk about trans theoretical later, but this is just straight up problem solving. And we're calling upon the expertise of this individual, and we're collaborating with him to figure out, you take your insulin at home, but you're getting hypoglycemia at work. It seems like we need to make sure you have some carbohydrate to go with that insulin. What do you think you could try? What would work for you? And so we just throw out ideas. It's like a brainstorming session. And then, oh, he figures out I could just eat, RT figures out I could eat a granola bar in my car on the way to work. Done. So we do a lot of problem solving with people living with diabetes, and that is very beneficial because it reinforces their knowledge about themselves and also helps them prevent hypoglycemia and other consequences or other events that might be difficult for them to manage. Okay, so we're going to reassess treatment plan and bring barriers to light. Gosh, people have competing demands. What if RT needs to get his household together and mobilize family members, or maybe they have pets they have to take care of? Who knows what's going on? So we also want to problem solve around that. Maybe they have lack of knowledge that, oh, you need to have a carbohydrate with insulin. I run into that a lot. Some people will say, well, I'll have some cheese or some peanut butter. They don't realize that they need carb to go with insulin. So we reinforce that and then help with problem solving. There may be literacy barriers. Maybe they don't really understand what is a serving of carbohydrate. We want to use different approaches to help them really assimilate that information. There could be distress or depression. It's just so much effort to give insulin and eat something afterward. I'm just barely able to get up and get to work. What about they're not really sure how insulin works? Maybe they have some misinformation about it. And then if we also want to look at their financial situation and their access to resources and involve mental health professionals and social workers and other community assistance as needed. So this is such a big, important part of what we do. And I would say I spend a lot of my time with individuals problem solving, pulling on their expertise and then helping come up with an answer that works best for them given their life situation. Okay, we have another poll question. Which phrase represents the principles for communicating with and about people living with diabetes? Your BMI indicates you are in the obese category. B, your fasting blood sugar is above normal. C, you should try and exercise 150 minutes a week. D, you are checking your blood sugars daily. Let's launch this poll question. We'll take about 30 seconds. All right, I'm going to close the poll. Well, okay, there we go. Some more folks have voted. I'm going to close it and share your results. So 31% of you said B, 69% said D. What is the best answer? So nobody chose A, which is great because we're moving away from using this word, saying to somebody, well, you are obese or a person is obese with diabetes. The language we're moving toward is a person with higher weight or a person in a larger body. So that would be a different way to describe a person that has a BMI of 30 or greater, or you could say a BMI of 30 or greater without labeling it. So this is part of the language movement to really recognize how our language affects people with diabetes and what we're really wanting to communicate. So why is B not the best answer? Because it says here, your fasting blood sugar is above normal. We're really trying to move away from that word normal, because if you're not normal, what are you? You're abnormal. So we would use a more neutral word, like it is above target range, or people without diabetes usually have fasting blood sugars 100 or less than 100, and your blood sugar is 128. So just comparing the two numbers and what the values represent instead of assigning a value to it, saying it's normal or not normal. I know we use this a lot in the medical field, but for people that aren't in the medical field, they're like, what, I'm not normal? So we're just trying to move away from stigmatizing language. This one, nobody chose, great job. You should try and exercise 150 minutes a week. While we do want to encourage people to be active 150 minutes a week, that's accurate. It's the should word. So we're trying to stop shoulding people or shitting on people, right? We're just trying to stop using that word because it's very kind of, there's a little bit of condescension in that tone of should, you should eat right, you should exercise, you should avoid alcohol, wherever we use that word. We want to use person-centered language, a strength-based approach instead, which I'll show you in a minute. Okay, you are checking your blood sugar daily. Yeah, it's just stating what they are doing in a very non-judgmental way, just recognizing the truth of the situation. And it's affirmational. You are checking your blood sugar daily. So you're recognizing the work they are doing, which is terrific. Okay, so D is the best answer. 70% of you chose that. So the old way and the new way, this comes from the use of language in diabetes care and education, published in 2017. This is when this whole language movement really kicked off the ground. And that is, we used to say, oh, you need to control your diabetes. Well, y'all know there's so many different things that affect blood sugars. You can't really control it. You can manage it. You can do your best. You can provide interventions, but it's not about getting it perfect. Control kind of implies you can get it perfect if you try hard enough. No, we manage it, knowing about 80% of the time we want to get it in target range. Even time in range is 70% of the time. So, we're not saying you need to do it 100%. That's not realistic, and it sets people up for failure. And sometimes I recognize in a lot of individuals I work with, they want to do diabetes perfect. And if they can't reach that goal, sometimes they just say, forget it, and they might go on a diabetes vacation. We don't want people to burn out. We want to make sure that we're setting up goals that are realistic for them to achieve and a plan that is realistic for the long haul. We don't test blood sugar anymore because you test as pass or fail. We check it, we monitor. We don't use patient. You'll notice I don't use that word patient, only if they're in the hospital. I might use that language. Participant, individual with diabetes, person living with diabetes are different ways we can say a person who lives with prediabetes or diabetes. They're only a patient if they're in that hospital setting or sometimes in the clinic setting. Normal blood sugar, don't use that word. Blood glucose in target range, not adherent, non-compliant, we don't use that language anymore. What we do is we focus on what they are able to accomplish. What we say matters. The person respects the healthcare professional, right? They really kind of look up to us in a way, and then whatever language we assign to them, they might take on for themselves. Our body language also communicates and shares information with them. So speaking the language of diabetes, how we talk to and about people with diabetes plays an important role in engagement, conceptualization of diabetes and its management, treatment outcomes, psychosocial well-being. For people with diabetes, language has an impact on motivation, behaviors, and outcomes. So this is a beautiful paper. If you have a chance to read it, this is at ADCES. They have a little tear sheet that you can share with individuals, with your colleagues, to say, hey, this is a language that we're moving toward, because we know historically stigma and shame has been attached to diabetes, and that can really lead to feelings of self-judgment and feelings of doubt that they're able to manage their diabetes successfully. I also have a webinar that's free and available. What we say matters, language that respects the individual and imparts hope. So you can take a look at that too. Let's move on to learning and behavior change theories now that we've kind of set the framework for this presentation. And we got this. What theory works best for you? Well, you get to go theory shopping and see what fits you best. How well does it resonate with you? Does it extend your thinking? Does it help you think outside of your usual box? Does it challenge you in new ways? Does it a way that you go, oh yeah, that would really work for me? How useful is it in providing education and support? Maybe you like one more than the other. That's okay too. So you can figure out which one works best for you, but for any exam, you want to be familiar with the ones I've listed here. So you want to be familiar with all of these, and you might notice yourself using different parts of these theoretical models as you're providing diabetes care and education. I certainly noticed that. Like, I'll do a lot of pivoting and saying, this approach isn't working, let me try this approach. Let's take a look at LS. LS arrives late for an appointment and says they forgot their logbook. LS has only been taking their metformin a couple of times a week and has gone back to getting fast food each morning for breakfast. What feelings would this evoke in you? And if you wouldn't mind typing on the right-hand side, like, what feeling would that evoke in you? If they came late, they forgot their logbook, they've only been taking their metformin a few times a week, now they're getting fast food again, you kind of had collaborated and made a goal not to get fast food, or just to get it unlimited times every week. What feelings would this evoke in you? If you wouldn't mind just typing in your feelings, that would be great. And I put some examples of feelings that might come up. Well, LS doesn't care, they're non-compliant, they're lazy, we better scare them, exasperation, or would it evoke a different feeling in you? I'll just wait a few seconds to see if y'all type something. There's a little delay, so I want to give y'all time, but also keep moving forward. So that's always my dilemma. Okay, there's some responses coming in. Thank you. I'll wait a few more seconds. Okay, so I'm not going to use names, but I just want to share what y'all typed. Someone typed non-compliant, but curious of the why. Someone said doesn't care, or that they don't understand the importance. They may be having a lot of social issues. Don't show my frustration, but ask how I can help them. What are their ideas? I like that. Don't show my frustrations. You're going to have a poker face. Discouraged, wondering how we can move forward. I would have concern. Is something happening in their life causing them not to engage with their diabetes care? I feel LS is non-compliant and may need more education on the disease. Okay, thank you so much for being courageous enough to type your responses. I so appreciate it. So what I would say when someone comes in with this situation, it might evoke a feeling in us, right? And we want to recognize that feeling. We want to be present with that feeling. We just want to be gentle with ourselves and just, you know, kind of recognize what response that evokes in us. But what I would really encourage us is to have the feeling of curiosity and to say, I wonder what's happening. So I think in the old days, we would say, okay, the person makes a goal, they go home, they need to achieve this goal and come back, and they're going to share with us that they've achieved this goal. And yes, that's great. But what happens is we make goals together and the person has all the intention of achieving these goals, but then life gets in the way, right? There's barriers that they hadn't considered. Like they've only been taking their metformin a couple of times a week. So we could say that's non-compliant, or we could look at it from a different vantage point that, oh, at least they're taking it a few times a week. So that would be a strength-based approach. So we're moving away from non-compliance to a strength-based, saying, oh, they're taking it a few times a week. So that's a good sign, at least they're getting it in. And they've been getting fast food each morning for breakfast. So this to me is, what happened? And a lot of you mentioned that. Is there something that changed in their social situation? Are they stressed out? Are they struggling with diabetes distress? Are they, what else could be happening? And so when I see this situation, I'm going to say, oh gosh, I know when you left last time we talked about taking them metformin daily, and I'm just wondering what happened. And maybe it's not a good time for them to take it in the morning. Maybe taking it in the evening is better. Or maybe they were supposed to take it 3 times a day and they can't achieve that. Maybe we can simplify the regimen. And then we can also discuss, if they do go for fast food every morning, what are some healthier choices? And this is going to go on for the lifetime of the individual with diabetes. They may have goals they've set forward and they may be able to achieve them completely, partially, or not at all. And it's totally okay wherever they land, because we're going to come back together in a collaborative effort to figure out, hey, what is realistic for you right now? And how can we tailor this education to meet your needs? That's what a strength-based approach does. And that's what we're moving toward, because our expectations of individuals can really impact their ability to succeed or to really struggle. And so if we go, gosh, you're not taking your metformin, you're eating out every day, we had different goals, I'm not really sure what happened. So if I approach it like that, you can see they can tell I'm disappointed in them, and they might feel so bad. And they might say, gosh, my provider just is so disappointed, I'm not going to really try that hard anymore. Or we could change the way we approach it and say, wow, you're taking the metformin 2 and 3 days a week. That's terrific. How can we make sure that on the other days you succeed at the metformin? And so now I'm changing the expectation of that situation, where I'm saying, I believe in you. You're doing it a few times a week. How can you do it more? So that changes that relationship, that moment, to one where the person maybe believes in themselves that they can do it. So the person labeled may take on attributes. If we feel this person is non-compliant, that shows up in our body language and our words and our facial gestures. People pick up on that, and they might feel like failures. We don't want people to feel like failures, because diabetes lasts a long time. Our language choices are so important. Our body language, how we support people, can make a big difference. And if people are not showing up for their appointment, we certainly want to think, why are they not coming? Is it the way I'm phrasing questions? Do they feel like that if they don't do everything 100%, that they're going to disappoint you in some way? And so I've really modified the way I approach this conversation over the years to give people room not to be perfect. Super important. Okay, thank you for having that great discussion. Poll question 3, which of the following strategies are best used when someone has low literacy skills? A, speak slowly and clearly. B, underline key points on educational materials. C, direct the teaching to the support person and encourage reinforcement. D, be concrete and focus on problem solving. Okay, low literacy. What would be the best approach? Will we speak slowly and clearly, underline key points on educational materials, direct the teaching to the support person, or be concrete and focus on problem solving? Okay, I'm going to close the poll. Thank you all for taking a risk and making a choice. So 13% of you said A, speak slowly and clearly. 25% said direct the information to the support person. 63 said, well, just be concrete and focus on problem solving. That is the best answer. So let me just say something about low literacy. I work with a lot of people who've immigrated from Mexico, and Spanish is their first language. So they have a lot of challenges navigating the world in English. And many of them didn't get the opportunity in Mexico to finish past elementary school. So many of them are not able to read either English or Spanish, so they would be considered low literacy. But they are bright, they are intelligent, they are resourceful, they are out there working, earning money, paying rent, paying bills. I mean, it's pretty amazing with their limited literacy, what they're able to accomplish. So my point is, low literacy does not mean that person is not intelligent or fully functional or very bright and wise. A low literacy just means they didn't have the opportunity, or there were barriers from them acquiring the ability to read and or write. So we don't need to speak slowly and clearly. And the other thing is, we're not going to direct the education to the support person. This person has agency. Even though they have low literacy, they have knowledge about their own selves and their capabilities, and they can help us understand what their goals are. So we're just going to be concrete and focus on problem solving. And they may not be able to write things down, obviously, or we can't give them a list of what we've discussed. But people who have lower literacy oftentimes are really great at remembering things, storing information, because they don't have that ability to write things down to remember them. They might also do little voice memos in their phones to remember things. That's another strategy we could use. So this is kind of a question I threw in, but I think it's so important as we navigate, literacy issues and identify if individuals are struggling with that, how do we approach it? We're going to be concrete, focus on problem solving, which we would actually do for anyone. Guiding language principles. We want to be strength-based. What does that mean? Emphasize what people know, what they are doing, what they can do, that they are taking the metformin. Focus on their strengths. Like, I know in the past, you've come through a lot of difficult situations. I believe you can take that resilience and that ability to problem solve to your future. When we say that, people go, really? You think that about me? They don't say that out loud, but it's a healthcare professional letting them know they believe in them. We want to use words that indicate awareness, that they are person-centered. I see you, I hear you, you are important to me, what you're saying are important to me. A sense of dignity, positive attitude toward the person with diabetes. So we know that we are asking individuals to take an active role in directing their day-to-day planning, monitoring, evaluation, and problem solving. We need to evaluate perceptions about their own ability and self-efficacy to manage it. Maybe they really don't think they can do a good job with their diabetes. And so we want to reinforce that who knows you better than you. Explore past situations where they experience success. And we've already talked about this, use strength-based language. And we're giving them the message through our body language. We believe you can do this. We're going to do another poll question 3. TR is a healthcare professional getting ready to take their certification exam. They are interested in providing more person-centered care. Which of the following statements verifies they are on the right track? A, adherence to the diabetes self-care plan takes time. B, motivate individuals to engage in their self-management is the first step. C, adult learners do best when provided a step-by-step demonstration. Or D, create mutual agreement on the plan for the next steps. So what would let us know that this, okay, wait, hang on. This person getting ready to take the certification exam is considering a person-centered approach. Take a few more seconds. Okay, I'm going to close the poll, share your results. So 33% of you said motivate individuals to engage in their self-management is a first step. Now, this is a little bit tricky and it's a little fine-tuning here, but can we really motivate an individual? Probably not. The motivation has to come from within. And that took me a while to figure out. I thought if I am more, energetic and hopeful and cheerful, and I'm going to motivate somebody to do something. No, I can find the fire within them, but they have to motivate themselves. Motivation comes from within. So we can support people to engage in self-management, absolutely. So this one, just, not the best to answer, because even if you're not sure, look at B and D. So D is a better answer because create mutual agreement on the plan for the next steps. This is called collaboration. We know collaboration is one of the most important things that we're going to do when we serve people living with diabetes. So this is an example of that, creating mutual agreement on the plan for the next step. We're engaging that person, they have equal value, they have agency, they know themselves best, we're seeing and hearing them. This is why D is the best answer. So if you're getting ready to take the exam and you're like B or D, what's person-centered approach that recognizes and honors the individual? D does. Okay. If you chose something else, it's totally okay. I mean, this is just a new way of thinking. As a healthcare professional for many years, like when we first started, we were compliance model based. We're shifting way over to more empowerment model. So for mindfulness-based interventions, we avoid compliance, focus on empowerment and acceptance. We are mindful. And I just want to say one thing about this, that I serve probably 60% of my clients that I serve. I work in an Indian Health Services clinic, speak Spanish only. And so my Spanish has improved dramatically, but because Spanish is not my first language, I have to listen with my full body to that individual who's speaking to me. I'm looking at nuances, I'm looking at facial gestures, I'm listening to tone of voice, I'm listening to every word, I'm not thinking about what I'm going to do tonight. I'm just present. And this is really interesting to think about how mindful that makes me. And when people are speaking English, my hope is I can do the same thing for them. So we're just carefully listening, observing. We want to be present and hear people. And if you kind of think about when's the last time you went to a provider and were given a half hour or an hour just to share what's going on in your life and you were really heard, listened to, and seen, that is such a gift, y'all. It is such a gift to recognize that individual. Pay attention to your thoughts and feelings too. Don't judge yourself, but explore, acknowledge, and consider. Yeah. Sometimes I hear the voice of judgment come up in myself. I do. And I just have to say, wow, that's kind of, where's that coming from? Where's that judgment language coming from? And I don't beat myself up about it, but I just explore it. And over time, if we listen to that voice, acknowledge it, and explore it, the judgment becomes less present. I mean, we all were raised in different ways too. We all have our own life experiences that we bring to the table. So we need to recognize that. And we might have to do a little bit of shifting in the way we traditionally approach things. Question 4, MR has had diabetes for over 35 years and tells you they know everything about their diabetes, but their provider insisted they come see you to check in with their diabetes. What approach recognizes adult learning theory? This person's A1C is 7.3. So would you say, please share how you have been managing your diabetes? B, can I please see your ambulatory glucose profile? C, please demonstrate how to use your meter. D, are you meeting your targets 80% of the time? So this person says, I don't know why I'm here. I know everything. What approach recognizes adult learning theory? Okay, we'll wait a few more seconds. Okay, I'm going to close the poll. Okay, so show your results. 94% of you chose A. A few of you chose C. So A is the best answer. Adult learning theory says, I recognize your expertise in yourself. So A says, hey, well, tell me how you've been doing this. I'm really curious. Your A1C is 7.3. You've had, success managing your diabetes. I want to hear, how you've been achieving this success. Wow, how does MR feel then? That defensive posture that MR brings to the table is going to disappear. You saw them, you heard them, you recognize them, you're asking MR what they've been doing. It's such a beautiful way to connect with somebody and very meaningfully. Yeah, if we could ask C, but again, what's the best answer? This one, A, encompasses their whole personhood. This would just be one aspect of what they're doing. Okay, let's keep going. So adult learners are self-directed, just like you all coming here today. Why did you come to this webinar? Well, maybe you're taking the exam and you want to be comfortable with behavior change theories. Maybe you want to think about new strategies to provide diabetes care and education. But you felt a need to learn, and that's why you're here. So that's adult learners. We're problem-oriented. I don't want you just to tell me stuff I don't need to know. I want to learn stuff that's going to help me today, tomorrow, that I'm struggling with. Learn better when their own experience is used. So this is why I try to do poll questions and put you in situations, because I know as adult learners, that really helps the information sink in. And of course, active participation. The more we engage with the learning, when I just love this example when IT comes over and we have a computer problem and the IT is so smart, right? They just like, and they fix something and they tell you how they fixed it, but then they leave and you're trying to do it and you couldn't remember the steps. So we need, to get our hands on doing it and getting coaching to succeed. Most effective education includes demonstration, practice, and direct practical feedback. Didactic, just telling somebody how to do something, less effective. And I'm really loving YouTube right now for people who are going on CGMs or using devices, because YouTube has so much great information out there where people can use video learning to utilize and to give reinforcement or help them problem solve. It's so terrific. Talk less, encourage more. Make the behavior real. So like, for example, I would say, if your blood sugar goes to 64, what would you do? That is totally adult learning theory, making it real for that person, giving them a situation or a scenario and seeing what they would do. Oh, if your blood sugar is 300, what would you do? If you go out to a restaurant, what could you order first? We put them in these situations and then we can really think through. When you're going to that fast food restaurant every morning for breakfast, is there any foods that stand out to you as healthier than others that you could order? Honestly, guys, when people come in to see me, I might think, gosh, I know the answers. I know what this person needs to do, but my answers may not work for them. So when at the conclusion of a meeting, I'll say, oh, we've talked about this, this, and this. What would you like to work on based on these conversations? And what I thought was most important is not what they thought is most important. So, even though we think we know what they need, people really know best what they need. We just have to evoke it from them. Well, I'm going to talk about learning theories from the Art and Science book edition 6, Art and Science Desk Reference 6 editions, Chapter 3. They highlight health belief models, social cognitive theory, theory of reasoned action, and theory of planned behavior, empowerment, trans-theoretical, motivational interviewing. So those are the behavior change theories I'm going to talk about. Let's take a little break, stretch break. Yeah, and there's also an outline of what's on the CDCES and BC-ADM exam that you can take a look at, but certainly behavior change theories are on there. I want to be in this lupin field with this gentleman. That looks so fantastic. Okay, but we get to do a poll question instead. Poll question 5, JR is deciding whether or not to start on insulin. A1C is 9.8. Mom had diabetes and severe complications due to chronic hyperglycemia. What would best describe application of the health belief model in this situation? A, level of readiness. B, more likely to start insulin if knows someone on insulin. C, feels empowered to inject insulin. D, perceive risk of future illness. All right. JR is deciding whether or not to start on insulin. Okay, I'm going to go ahead and close the poll and show your results. So 23% said level of readiness, but most of you said perceived risk of future illness. So when you see, we're actually, I'm just somebody wrote a question. Okay, thank you. So we're looking at which of these describe the health belief model. And level of readiness is the trans-theoretical model. We'll get to that later. So this is, how ready a person is to take on the action is trans-theoretical. And B, more likely to start insulin if knows someone, that's social learning theory. So that is more like, oh, I'll do it if others do it. It's not asking for that one. It's health belief model. Feels empowered. Nobody chose that. That's the empowerment model. D is the best answer. Perceive risk of future illness. So the health belief model is kind of a cost benefit analysis. And it says, how vulnerable do I feel to having an illness if I don't take insulin? And what will be my perceived benefit if I do take insulin? They're weighing the cost versus the benefit. So individuals' perceived risk and seriousness of illness determine the likelihood of adopting preventive behaviors. So let's just see, JR's mom had diabetes and severe complications. So JR might be thinking, gosh, my mom had complications. I don't want to get complications. But maybe he doesn't feel that vulnerable. Maybe he goes, well, that was my mom. I'll be fine. So his level of personal vulnerability, how serious he believes the illness is, the person does. Maybe he's like, well, I just have, my diabetes isn't that bad. I'm fine. Efficacy of behavior in preventing or minimizing consequences of illness. Will this really work if I do it? And then the cost, time cost, financial cost, or deterrence associated with making changes. So the more perceived the risk, the more likely to make necessary changes. Okay, so cost versus benefit, how vulnerable they feel to that risk. And you can see this in individuals that we serve. Some people may say, gosh, I'm not going to go on insulin. I'm not ready to do that yet. It's not worth it for me. I'd rather try orals and activity and healthy eating. And then others might say, gosh, my mom had complications of diabetes. I'm going on insulin starting today. I want to reduce my risk of having those complications. So these are these influencing factors. Okay, so the other theory we just talked about was social learning or cognitive theory. People learn from their own and observing others, behaviors and consequences. So this is in social situations, what actions do people take? And I like to think about the weight loss medications and the GLP-1s that just hit social media. And then so everybody's seeing how these GLP-1s are affecting individuals' weights, and then people are clamoring for it, and many people are taking it. So that would be social learning or cognitive theory, where people are saying others are doing it, I want to do it, and they take on that activity. Health behavior is constantly changing and evolving interaction between the person and their environment. So just because we're taking the GLP-1 now doesn't mean we're going to keep doing it in the future. As a matter of fact, you know, many people over time are stopping taking that GLP, and that's kind of a health versus benefit cost analysis they're doing. I mean, a cost versus benefit analysis they're doing. Maybe that could be one example of using also the health belief model. Maybe it's not just worth it to keep on this medication for the future. So they may make that choice too. Okay, so we have the environment, their behavioral capability, their expectations on what's going to happen, they observe, and then they get reinforcement, self-efficacy. So this is another way that we see this happening is through diabetes self-management education and diabetes prevention program group classes. As you'll look at this, there's a lot of social learning and cognitive theory happening in real time, where people are sharing their stories with others. Oh, when I had diabetes at first, I was so mad about it, but over time, I was able to accept it more. And now I'm, you know, really kind of just engage with my diabetes on a daily basis. And they're like, really, you are? So that's very powerful. I love what Dr. Bandura says, who is kind of developed this framework. We are our connections. So who we hang out with influences our behavior. The other theory is the theory of reasoned action. Behavior change operates through three major constructs: attitude and beliefs toward the target health behavior. So suppose a person is smoking and they're like, well, yeah, I'm kind of ready to quit smoking, but I don't know, it feels so great when I'm nervous to smoke cigarettes. So that might be their current attitude. Maybe they're having a lot of issues and it really helps calm their nerves. Perception of how others in the public view the health behavior, the subjective norm. So in the past, everybody smoked, right? Well, it seemed like everybody smoked, but everybody would go for a break and have a cigarette. But now there's much more different social pressure. It's not to smoke. People don't want other people smoking around them. They have to go outside. They have to stand away from the building. It's changed over time, the social norm. Extent to which the individual believes they are equipped with the knowledge, skills, and ability and accessibility to perform the behavior. So does that person think, yeah, I can quit. Maybe I'm going to start on some Nicorette gum or some other pharmacologic agent to help support me quitting. I think I can do this. So these three work together and clarify and predict the person's intention to engage in the target behavior. So this is interesting too, as you're working with individuals and maybe they want to start moving more. What is their belief and their attitude about movement? How are others going to perceive it? And do they feel like they can do it? Behavior change is super complicated in an individual. Like we're saying, oh, it's really important to, you know, exercise or get active 150 minutes a week. Super easy to say, but how does a person actually make that happen in their life? It's a lot more complicated because there's so many factors, moving pieces to consider. Which of the following statements by the educator best reflects the empowerment approach? We are here to help motivate you to get your A1C to target. Do you think if you make a concentrated effort, you can achieve an A1C less than 7%? What are some reasons you want to lower your A1C? I believe if you follow our suggestions, you will achieve your goals. Let me launch this. I'll wait a few more seconds. Okay, I'm going to close the poll because we have consensus. 100% of you chose C. Great job, team. Yes, that is an empowerment approach. Instead of saying, well, you need to lower your A1C to prevent complications, which we could easily say, and that's actually super accurate. What are some reasons you want to lower your A1C? So empowerment approach is so empowering. No, it really recognizes the strength of that individual and their knowledge in themselves. So we're moving away from non-compliance. People with diabetes are asked to take an active role in directing the day-to-day planning, monitoring, evaluation, and problem solving. If we say that person's non-compliant, it denotes that they need to be passive or obedient, and they need to follow doctor's orders. We're not doing that anymore. And you know what, Olive, we tell somebody, well, you need to eat, 3 vegetables a day, and they come back and we say, well, did you eat your vegetables? That's a compliance approach. And it doesn't really help that person feel like they want to make that change, like it came from them. They just feel like, oh, somebody told me to do it. I'm not really invested in this. And then if they don't do it, the provider, like us, might feel like we're failing. We're not failing. We don't want to set anybody up to fail. We want to set people up to feel like they can be safe in our environment and share the truth of what's happening. We need to evaluate perceptions about their own ability and their self-efficacy to manage their diabetes. So here's empowerment defined, and that term's been used a lot. So I recognize that there's some overuse with this word, but man, it's such a powerful way to support people in living with diabetes. Helping people discover and develop their inherent capacity to be responsible for their own lives and gain mastery over their diabetes. The posits are choices made by the individual have the greatest impact. Individuals are in charge of their management. The consequences of self-management decisions affect the individual most. It is their right and their responsibility to be the decision makers. So if you're taking an exam in the future, and just really to kind of see what is the difference between traditional DSMES and empowerment-based. Well, traditionally, we would see diabetes as a physical illness, but empowerment says we understand it's a bio, psycho, social illness, which is such a better definition of what diabetes is. Professional is viewed as a teacher and problem solver. Over here, in empowerment, the person with diabetes is viewed as a problem solver and self-manager. Professional acts as a coach and shares responsibility for outcomes. So we're collaborating. Learning needs are usually identified by the professional, and over here in empowerment, problems and learning needs are identified by the person with diabetes. It just makes sense. It makes sense. So I would encourage you to download this, read it, be familiar with it, and have it integrated into your DNA before you take the exam. It will totally help you. Empowerment-based self-directed behavior change protocol. Define the problem. I love these questions. Even you could steal these questions because they're so great. What part of living with diabetes is most difficult or unsatisfying for you? And then figure out what the feelings are. How does that make you feel? And then long-term goal. How would this situation have to change for you to feel better about it? What barriers will you face? How important is it for you to address this issue? What are the costs and benefits? They brought up some health belief model there. What are the costs and benefits of addressing or not addressing this problem? So we want to identify short-term behavior change experiments. And I like this word experiments instead of goal, because you can say, let's just try this until we see each other next time. It's an experiment. Let's see if it works or if it doesn't work, and do we need to make adjustments? There's less pressure on that individual. And then they come back, how did that plan we discussed at your last visit work out? What did you learn? What would you do differently? What will you do when you leave here today? Oh, those are such great questions. Okay, moving on. A person says, I am ready to start eating 3 vegetables a day. Using the trans-theoretical model, what stage of change are they in? A, pre-contemplation, B, contemplation, C, preparation, D, action, E, maintenance. I am ready to start eating 3 vegetables a day. Using the trans-theoretical model, what stage of change are they in? Okay, I'm going to close the poll and show you results. So interesting, 5% of you said pre, 16% contemplation, 11% action, but most of you chose preparation. Is that right? It actually is. Great job. Okay, but let's just talk about this if you chose something other than preparation. So I am ready to start eating 3 vegetables a day. Is that pre-contemplation where they're not even considering it at all? No. If it was pre-contemplation, they would go, vegetables? Yuck, that's pre-contemplation. Contemplation, I'm not sure if I'm ready to start eating vegetables. That's pre-contemplation, right? They're thinking about it. But this person is in preparation. I'm ready to start eating. So they're ready. Have they done it? Nope, they haven't done it, but they're ready. And maybe the next sentence would say, okay, how are you going to get to the action part where you're actually eating vegetables? Well, today after I leave the office, I'm going to go shopping, get myself some vegetables, and that I'm going to start eating 3 vegetables a day. So they're in preparation. They haven't entered action yet, because if they were in action, they would say, I am eating 3 vegetables a day. Okay, let's keep going on this one, because trans-theoretical model, it's a little, it just takes a while to get comfortable with it. But pre-contemplation, I'm not ready. Contemplation, I'm thinking about it. Preparation, I'm getting ready. Action is doing it. Maintenance is keeping going. And then termination, hit a roadblock. So here's the faces. This might help you. I'm trying all these different approaches. I'm using adult learning theory. Let me see if I can help this to sink in for you. Here's pre-contemplation, vegetables. Contemplation, maybe I should eat more vegetables. I use the should word. I would like to start eating more vegetables. Preparation, I am ready to start eating vegetables. Action, I am eating 2 to 3 vegetables a day. Relapse, I just stopped eating vegetables like I used to. Okay, so this is down here too. No, maybe, okay, I want to, I'm doing it. And then people relapse all the time. So I actually help people be prepared for this. Like, hey, you might be on this vegetable roll for a while, but if you get to a place where you're eating less vegetables, again, it's okay. Let's talk about it so we can help do some problem solving around that. And so we always want to give people permission, because if they get stuck and they stop eating vegetables, they may be embarrassed to come back and see us. We don't want that to be the stop from them coming back for their appointment. We want to always provide support and encouragement, knowing we're in this for the long haul. I wrote out the trans-theoretical model for you. So here they are. You can take a look at this. I just wanted you to have it so you can read it and let it just sink in, and be comfortable with this language and these different stages of change. Let's do another one. A 49-year-old started bike riding as part of their goal to lose 14 pounds. Using a trans-theoretical model, what best describes their state of change? Are they in action? Are they in contemplation? Are they in termination? Or are they in pre-contemplation? Okay, let's see what y'all say about this one. Okay, we'll take about 10 more seconds. All right, I'm going to close the poll and say, yay, awesome job. 100% of you chose action. Yes, this is action. They started bike riding as a part of their goal to lose 14 pounds. Now, we know that bike riding by itself is not going to help them, achieve this goal. It will support them in getting healthier, but we're so excited they are moving their body more and being more active, and that will be coupled with healthy nutrition, seeing the dietitian, getting some coaching, and supporting their goal to lose that weight. Okay, so they are in action. I love that. Great job, team. So how to succeed with person-centered coaching? A diagnosis of diabetes often carries a significant emotional response. A person might report that they feel shame, fear, or guilt as they come to terms. As diabetes healthcare providers, we can learn to address these feelings. So we want to acknowledge feelings and say, gosh, I can imagine you're feeling scared. This is scary. I have good news for you that, people with diabetes often use the diagnosis as an opportunity to make changes in their life that they've been putting off. Does that resonate for you at all? I might kind of bring it up that way. We want to use a person-centered approach to identify their expertise and their strengths. And our choice of communication techniques can actually spark behavior change in people living with diabetes. And that's what we want to do. So in motivational interviewing, which is another strategy or tool we use, the primary goal is to evoke intrinsic motivation within that person and commitment to change by creating a collaborative and non-judgmental atmosphere. I love that. What a great approach to supporting people and making these difficult behavior changes. The approach recognizes that individuals often have mixed feelings about changing their behaviors, and it aims to guide them towards resolving this ambivalence in a positive and constructive manner. So I have a little cheat sheet. If you go to my cheat sheet pages go to my website, diabetesed.net, and go to free. And under free, it says cheat sheets, and I have a cheat sheet on person-centered coaching that I think you'll find super helpful if this is an area you're kind of trying to move into or you want more reinforcement on. But one of the first important stages is expressing empathy. And I just want to say asking questions is such a great strategy. I notice if I'm giving a lot of information and not asking questions, I feel like I'm on the wrong path. If I'm asking questions, learning more about them, hearing what their life is all about, what works for them, what doesn't work, I'm on the right path for me. The individual feels heard and understood. Then we want to roll with resistance. If they say, I don't want to eat vegetables. Oh, okay. I hear what you're saying. Vegetables are really not something you want to work on. Can you tell me more about that? Look at that. So you recognized you heard them, and then you want to hear what happened. Well, my mom used to make vegetables and they were super soggy and gross and I just hate them. Oh, is there any vegetables that you eat now that you enjoy? Okay, so now we're getting some momentum. We want to support self-efficacy, enhance the belief in their capacity to change. We've been saying that a lot today. Develop a plan. If they're ready to make one, we'll kind of collaborate to figure out what is a plan, and avoid arguing and confrontation. It doesn't work, and it might just shut people down. They may not share the truth with us, and they may not show up for their next appointment. So sometimes we can go more quickly moving, working with people on collaboration in this way. Other times we really have to take baby steps. So it may be hard for us sometimes to pull back, hold back a little bit, and not push too hard. So relationship building, we want to ask open-ended questions, we want to listen actively, and we want to engage with that individual in a way that supports their ability to make these changes. And this is all under this umbrella. Okay, here's the cheat sheet I was talking about, how to succeed with person-centered coaching. It's on our website, and it's just a real nice cheat sheet you could even share with your colleagues. So we want to mindfully listen to the individual's problems and fears. I just wrote out a little strategy here. So we have a truck driver, and this truck driver wants to eat more vegetables, but it's hard because they're on the road a lot. So we're listening and reflecting back the struggles of the individual. It's the first phase of energizing the visit. Oh, we're energizing the visit. It's hard to eat more vegetables because you are a long-haul truck driver. See, this is interesting because it doesn't say, oh, vegetables are good for you. They have fiber and micronutrients and phytonutrients, which we kind of want to say. But instead we're saying, we're just getting into that person's worldview and saying, oh, it's hard for you to eat more vegetables. I hear what you're saying. We're going to acknowledge what they're saying. It's hard for you to eat more vegetables because you are a long-haul truck driver. And then we're going to focus on curiosity before exploring possible changes to open the door. As a truck driver, so we're going to ask this person and say, as a truck driver, I'm curious to learn more about your food choices when driving. Oh, curiosity. So the person's like, oh, I want to share with you how I deal with this. With the person-centered approach, we can spend more time in curiosity before moving to action. And then we say, we listen for ideas. And what are your ideas about the situation and how you can improve it? Well, and then the person comes up with this idea. I could buy a veggie tray before heading out in my truck. wow, they came up with that by themselves, and then ask questions. So instead of saying, yeah, that's a great idea, you could buy a veggie tray, which I really want to do, we're going to calm down and just say, oh, so you think you could buy a vegetable tray before heading out. So now what we're asking them to do is say, yeah, and then we want to kind of help them develop a plan when they would do that, how they would keep it cold, where they would store it, you know, the logistics involved in that. And then we say, you think that's realistic for you? Yeah, I think I could do it. We're building self-efficacy. Okay, which of the following is a SMART goal? I will buy a veggie tray every day. I will eat more vegetables. I will monitor my blood sugars on a regular basis. Or D, I will buy a veggie tray at least twice a week for a month. All right, I had an extra word in there. Which of the following is a SMART goal? Okay, you all are on fire. 100% of you chose D, yes. Why is D the best answer? Well, because it's SMART. And let's take a look at what SMART means. It's specific, measurable, attainable, relevant, and time-bound. So what is it going to do? Buy a veggie tray. How often? Twice a week. How long is it going to last for? A month. He came up with this idea. This person came up with this idea. So we think it's relevant and realistic, and it's helping support this person achieve their goals. So what do we want to avoid? We want to avoid pressuring, fixing, controlling the situation. Our job is to help the person with diabetes find their own answers and solution. Let's stop shitting on people. It's time to let go of terms like you must, you should, you have to, it's better, it's important, do it for me, since they fall under the category of controlling motivation, which can be hurtful and lead to individual becoming defensive or shutting down. And ditching the scare tactics. We know that scare tactics don't work. They might alienate that person. We want to lean into their strengths. So we want to lean into a person-centered approach, which energizes the individual to take the lead in managing their condition and step with their providers and supporters. And that little communication sheet that I put together is a sheet you could share with your colleagues and teammates, especially if you're in an environment that doesn't support person-centered approach. So in conclusion, let's celebrate and recognize each person's effort. Making behavior changes like healthy eating or adjusting lifelong habits can be really hard, even for us healthcare professionals who are super smart and know all about it, right? Find a way to recognize and affirm their efforts, even if there's no or little change in their clinical measures. Like, for example, a person's really trying to decrease their weight and they come in and they weigh themselves and it's still the same. You know, how we approach it and the feedback we give is going to be very critical. And I might say, would you be willing to consider that you're making healthier food choices and moving your body more? And that's just contributing to your overall well-being. The scale is just one measure of, you know, getting to your goal, but how you feel every day in your body is very important to consider too. Our belief in people makes a difference. So that concludes our webinar on behavior change theories made easy, but that doesn't mean we're not going to keep in touch. We offer a lot of information on our social media platforms, Facebook, Twitter, Instagram, LinkedIn. We have a monthly newsletter. We have blog bites. We have question of the week. We have different ways that we can keep connected. So I hope that you're able to check some of these out and, you know, share with others. We actually have a Facebook group. It's a CDCES certification Facebook group where people are supporting each other on their journey to become certified and doing a lot of great information sharing. And if you need help finding it, you can email us or chat with us and we will definitely get you started in our groups. So if you have any questions, we're happy to answer them. You can email us, you can phone us, you can chat us. We're really available to you. Brent and Brianna are doing such a great job of making sure that we support you on your journey and answer your questions along the way. Thank you so much for joining us. I'll hang out and answer any additional questions after class. But for now, this is Beverly Thomassian saying thank you and signing off.